And our today's lecture is on PET-guided LINAC RefleXion X1. And we have two great speakers today, Doctors Lucas Wіцтум and Daniel Pham. And the audience already knows them from our previous talks. Instead, I will share maybe the origin story of RefleXion X1, as I find it really fascinating. The founder of RefleXion X1, Sam Mazin, was a grad student here at Stanford in radiology. And after attending the lecture by our director of medical physics, Lei Jing, who gave the last talk, Sam had this great idea of using PET signal from the tumor itself for biological guidance for radiotherapy treatments. So he went home and he researched if this technology already exists, and it didn't, so he got to work. He filed for patents, did a lot of research, developed a machine, founded RefleXion Medical Inc. He found investors, and then created this first PET-guided LINAC. And 12 years since that lecture and that original idea, we treated our first BgRT PET-guided treatment here at Stanford this August. So it's quite an amazing story. And for today's talk, there are two parts. First, it's a clinician's perspective on BgRT by Dr. Wіцтум, and the planner's perspective on IMRT and BgRT by Dr. Pham. So please take it away, Lucas. I'll stop sharing.
Great, thanks, Natalia. All right, great. So we'll be talking about PET-guided radiotherapy today. For disclosures, we do receive some funding in the form of research grants from RefleXion. For the outline for today's talk, I'll start out talking about this technology from a physician's perspective, what we think the clinical needs are that this technology could meet, really what this technology means to do PET-guided radiation therapy, our clinical experience thus far, and then future directions. And then hand things over to Dr. Dan Pham, who will talk about things from the dosimetry perspective, including image-guided radiation therapy on this machine, which it can do, and then biology-guided radiation. So I think we can all agree that there's an expanding role for local treatment in patients with metastatic disease. We won't go over all of these data, but here is just a nice summary showing for non-small cell lung cancer, general oligometastatic disease, and then prostate cancer. Mostly phase 2, one of these is a phase 3 trial, but showing improvements in progression-free survival and even some of them overall survival. And it's something that's being looked at in ongoing phase 3 trials. There's also, so oligometastatic, we think of a limited metastatic disease state where if we treat all the lesions, we can alter the disease course, hopefully extend their life, and maybe even in some patients cure them. Oligoprogression is another type of or another disease state where I think there's a role for ablative radiation, and that's where you're on a drug, a select site starts growing, and we ablate that with radiation to extend the life. And some data out of MSK with the CURB trial that shows, and at least the strategy improves progression-free survival. But as we start treating more mets throughout the body, there are some unique challenges with scaling our current SABR techniques to doing all throughout the body. Motion management is one of them. Things move differently depending on where they are. We would ideally have real-time imaging of tumor. Again, if things are moving independently and we're moving up or aligning just to one tumor, it's hard to say what's going on with another one. And then finally, in an ideal scenario, we'd be able to treat some of these lesions in parallel, so not having to treat, do multiple SIMs and treatment sessions for all the different locations. An ideal solution would be to just scan, make a plan for each one, and kind of put the patient and treat them. The role for radiation in metastatic disease is something that has been kind of dictated by the available technology thus far. So the idea of oligometastatic disease came about in the 90s. There's an editorial by Hellman and Weichselbaum, but really didn't have good technology to do ablative radiotherapy throughout the body. So you can see a picture here of LA1 that was at Stanford decades ago, and then here's a plan for LA15, the 15th linear accelerator at Stanford. You can see there's much more conformal, precise treatment. So we think potentially with biology-guided radiation therapy, there's still a ways to go, and we'll talk about that. But hopefully it can also, unlock new roles for radiation therapy going forward. So what is this technology? What's called PET-guided radiation therapy, also known as BgRT or biology-guided radiation therapy, or Syntex is the new kind of brand name for it. I think most of the presentation will use the term BgRT, but these are all interchangeable. This is a novel radiation modality that uses PET as a tracer to track and treat tumors in real time, where the radiotracer actually acts as a biological fiducial to track the tumor. We've talked about this technology before. Sometimes folks will say, well, I can get a PET, I can get a CT, I can confuse them. What's the point of this technology? And really the key here is that it's using that signal as a tracer for motion management in this closed loop system. There is a unique dosimetry and workflow that we'll go over. And it's currently approved for FDG PET, although we're actively investigating other radio tracers. So BgRT is done currently on the RefleXIon device. This is what it looks like. Just briefly, the heart of the machine is a 6 MeV linear accelerator that's coplanar with PET dual 90-degree arc PET detectors. So on the same isocenter, the machine will detect PET and then deliver radiation. There's also a KVCT that's on the machine, although not isocenter, that's used for localization. This KVCT has actually been great for image-guided radiation. These are some slides thanks to Drs. Kowalczyk and Pham put this together, but you can see here a planning quality CT, and it is a fan beam CT, so really near diagnostic quality CT. And you can compare that to a cone beam with all this artifact, and really the soft tissue resolution is just not nearly as good. So this is independent of the BgRT, but one of the highlights of the machine. Similarly here, looking at the pelvis, you can see just the pelvic organs much clearer on this, the fan beam CT as opposed to the cone beam. So how do we use PET as a biological fiducial? It is this unique engineering and signal processing challenge to go from here, which is the raw PET signal, to something that you could actually use to track and treat a tumor. And we'll go over how this system actually does that. So one of the first things it does is it applies a mask to eliminate all of the signal outside of the region that we're interested in. This region that we're interested, we call the biology tracking zone. So we contour the GTV like we normally would, add a PTV, and then contour the motion extent, which we get from a 4D CT, and then contour out with an additional centimeter margin this biology tracking zone. You can kind of see that here of this red. So the machine just looks everything inside of there. And then finally, for how it actually delivers the radiation, it's different from conventional SBRT. So conventional SBRT, you get a CT, and then through the planning process, you solve for a series of fluences from different angles. In this case, it's a ring delivery or an arc-like delivery system, although it's static, from different angles that would add up to a desired dose. The BgRT is a little bit different in that it actually, instead of solving for a fluence, it solves for firing filters based on the PET projections that are being acquired in real time. So there's an additional PET planning scan, and based off these partial PET signals, it figures out what firing filter to have to apply to get a total dose, like your desired dose, and then ultimately solves for this firing filter. So the dose you're delivering on the day of treatment is dependent actually on the PET signal. If the PET signal changes, the dose will change. And there's different tests and quality assurance measures that we have to make sure that our PET or our delivered dose isn't deviating too much. And that was one of the key questions that we had for commissioning this technology and investigating is, are we going to see these big swings in the PET signal, which will change the actual dose? This is what the clinical workflow looks like. You can see there's additional steps. We can simplify this a little bit and kind of what we're currently familiar with. So there's a CT simulation, which is what we normally do. And then there's an additional BgRT planning scan. You put the contours in like you normally would, and the patient gets scanned actually on this X1 device. And then from there, it actually do the BgRT plan creation. And then it looks like optimization similar to current workflows. And then for every delivery, the patient would undergo a PET injection, set up on the machine, and then delivery. So we have some evidence for this approach from a clinical trial that was conducted here at Stanford, as well as a clinic in Texas, UT Southwestern. And this was the trial that generated data for the FDA application to get this, this technology approved. There's two cohorts. The first cohort was looking at identifying the FDG dose that was required to get an adequate signal. And then the second cohort looked at evaluating an emulated dose. So we actually didn't deliver radiation, but these are patients that were getting radiation on another one of our machines, and that we scanned them on the first and the last treatment, and then tried to see if we were emulating delivery, or essentially kind of did all the process and steps like we were going to deliver, and actually kind of pretended like we were going to treat them without actually delivering dose, and then evaluated, would that have delivered dose been similar to the predicted dose and the approved plan. So the inclusion criteria for this, we used bone and lung tumors. It could either be a MET or a primary. We used lung as an example where there's a good contrast between the tumor signal, which ideally should have a hot FDG, and then low background in the parenchyma, and then the bone, which is kind of more moderate. So uptake in the tumor, and then maybe SUVs of like 2 or 3 potentially in the marrow. The inclusion criteria for size were 2 to 5 centimeters. Wanted sufficient signal, so in this one we used SUV max of 6. And then it had to be away from FDG avid structures, so things like the heart, brain, bladder, anything like that that has just a high uptake physiologically. We wanted at least a couple centimeters away from that, because it is hard to not have the planning system actually put dose where it sees signal. The primary outcome for this second cohort, which was the primary outcome for the overall study, was that the proportion of emulated dose points to have 95% of those within this bounded DVH. This is a picture of the bounded DVH. It's a concept that's kind of borrowed from proton technology and robust optimization, where the system simulates some different variations in PET signal and tumor and OAR position, and tries to give you an example of kind of a likely, most likely scenarios of what your actual dose distribution could be. And we wanted to see again that 95% of things that were actually delivered fell within those bounds. So the results of this trial, in the first cohort, we found that our starting dose, which is an injected dose of 15 millicuries, had adequate signal. 6 out of 6 patients. We observed adequate signal for that, so we went on to the second cohort. And we're able to do 17 emulated deliveries. So did 9 patients and measured them on the first and the last day. 16 out of 17 resulted in adequate dose distribution and meeting that endpoint of 95% of the dose points within the bounded DVH. We then delivered the emulated plans to a phantom and found that they were all physically deliverable. And then importantly, we saw no toxicity attributed to the multiple FDG administrations. We're giving these patients a lot more dose or a lot more FDG injections than you would see in normal diagnostic use. They're going to end the day of SIM and then each day during treatment. So we wanted to make sure that there was no, unexpected toxicity with all of that FDG. Here's a few photos from the trial. On the left, you can see the CT images with the contours, and on the right, this is what the raw PET signal looks like. And you can again see, just by nature, the spatial resolution of PET isn't super precise. So there's a lot of signal processing and things in the back end that have to go on to use this as a tracking modality. The workflow, again, would be that on each day of treatment, you'd inject the patient and do a scan. And then before you actually start delivering dose, you get this evaluation where you see that our signal is sufficiently strong. So here we can see that it's above 5. We want our noise to signal ratio to be strong enough. So here it's 2 and we got a 4. And then we want to see that and 95% of our dose points are within the bounded deviation. In this case, there were 100. So these are 2 examples of successful pre-treatment evaluations. And then we proceeded to go on to emulated delivery. This is a summary from all of the patients that were treated, the activity concentration, and then the normalized target signal or the noise to signal ratio. And I'll point out that you can see that it does vary a bit across the different fractions. So this is, you can think of it like the signal strength. When people are asking, well, is your PET signal, and these are not just tumors that were, passive or not treating, these are getting active radiation. So, it's fair to ask, is the signal going to go down because you're killing cancer? Is it going to go up because you're causing inflammation? And there's really not a lot of great data because people typically don't get PETs during treatment. So you can see here there is variation day to day in both the absolute signal and noise to signal ratio, but importantly, it didn't result in enough deviation to actually change the dose distribution. So the absolute signal can change and there can be some deviation in the noise to signal ratio, but we're still getting accurate deliveries, or the deliveries are falling within the bounded DVH. As a result of this trial, again, the FDA approved BgRT for use for bone and lung tumors. It is specific to the radiotracer used on this trial, which was FDG. So we have started treating them clinically. Thus far, we've only done 2 patients. We're always actively looking for patients, but you can see from those initial inclusion X criteria, there still is a fairly narrow zone of patients that we can treat. You have to have the right size tumor, away from FDG avid OARs, and only bone or lung. So we're working to expand those criteria, but right now it is somewhat select. So we've treated complete treatment on 2 patients and have evaluated the post-treatment dose distributions, which have looked good. And we're actively enrolling these patients in a registry trial with quality of life surveys and clinical endpoints. So I'll take a pause now for a question. What radio tracer is biology-guided radiation FDA approved to use? Nice, great. Yeah, so exactly. The FDG. PSMA hopefully will be on the way shortly. There's a clinical trial going on south of us at City of Hope in Los Angeles or Orange County. I'm just looking at using PSMA, but right now it's just FDG. And then I've got a few slides actually going through the first patient that we actually treated with BgRT. So this is a 58-year-old female with lung metastases from colorectal cancer. She had previously been treated with 25 gray in 1 fraction to each target. And then had recurrence in this right upper lobe. It was a 2.5 centimeter tumor with adequate PET signals. So we decided to treat with biology-guided radiation. One of my colleagues did. We did a 5 centimeter expansion of the GTV and then that BTZ. So again, that window where we want the machine to look was a 1 centimeter expansion of the ITV. See the imaging here, the contours. So again, BTZ, this is kind of the envelope where the machine will look for signal. GTV and PTV are, I think, terms we're all aware with, or all familiar with. This is what the BgRT plan looked like. We did 50 gray in 4 fractions. And you can see here again the bounded DVHs. This is something, it's a newer concept. We're still learning how to properly interpret this, particularly on these edge cases. Learning what this really means, like how likely it is that we would get a point here. Like, for example, if we wanted to get 50 gray and most of the tumor was treated 45 gray, we think that's unacceptable. It's not exactly true, but you can kind of think of this as like almost like a normal distribution where the probabilities are probably more weighted around where the solid line is, with the dropping off as you get farther away from that, closer to the edge. So this is these solid lines represent what dose was actually delivered. You can see here too the PET signal, and then the dotted and dashed lines represent the expected isodose, the actual delivered isodose. You can see the PET signal lined up nicely, and then the delivered dose was highly aligned with our approved plan. Summing, and then so for this first one, we summed up all 4 fractions. And interestingly, we saw that the plant just kind of naturally accumulated dose more in the GTV than we expected. So the triangle here is the delivered dose versus what the initial plan was. So interestingly, without an increase in dose to the OARs, it just kind of naturally boosted dose to the gross tumor volume, which and generally, I think is a good thing, just getting more dose there, particularly for a resistant histology like colorectal cancer. So to summarize the first patient, each fraction took about an hour. The actual BMON time for 10 gray per fraction is about 22 minutes. So a lot of that time is involved in the different scans and setups. And having the machine compute that the dose is going to be delivered accurately. And then again, the target doses were higher for 2 fractions. And no adverse events reported with the PET injection or the actual BgRT delivery. So to take a step back on where we are with this technology, these are some R-ideal guidelines that were adapted from some surgery guidelines called the IDEAL guidelines, and they kind of put this roadmap for new technology and radiation therapy. Because importantly, it's different than a drug where you develop it in the lab, do it for like phase 1 trial, and then a phase 3 trial where you say, is this going to work or not, or really test efficacy. Technologies like this evolve a lot as they go. So if we were to do a randomized trial today, probably wouldn't be positive because we're still really learning what is the best use case for this, and we're also improving the technology. So I think this is a nice conceptual framework for to think of kind of a path for new technologies. I'd say we're somewhere between stage 1 and stage 2, and moving towards the 2A to 2B. So stage 1, they call it, this is first use in delivery in humans. It's ideas of proof of concept in the data that we're getting our case reports or more dosimetric data. Moving on to more optimization of the technology, and then exploring actually the effectiveness for toxicity, tumor outcomes, and then hope to eventually move to a more stage 3 design where we do a formal comparison to really show the benefit of this technology. So got another question. What best describes the state of technology currently to support BgRT? A, do we have phase 3 data showing there's improvement in overall survival? B, do we have phase 3 randomized data showing there's less toxicity of BgRT? C, do we have inhuman data showing that emulated BgRT delivery is accurate with delivered dose similar to physician group plans? Or D, is there no human data, only phantom data to support BgRT? Okay, nice. Yeah, exactly. We've got the agree with the C that we have inhuman data showing that the emulated BgRT delivery is accurate, but no actual data yet on clinical outcomes for things like survival or toxicity. So conclusions from a physician standpoint. Like every new technology, we need to understand its limits and use it judiciously to treat patients. This is something I think actually as a physician, our job is not nearly as hard as the physics team. So Natalia, Marat Sruchu, and a lot of our other team in DOSI has done a lot of the work here to actually make sure this technology is both safe and effective. And a lot of it goes on behind the scenes. So we definitely appreciate that. And going forward, I think with this new technology, it's kind of laid or paved the way for how we evaluate this, and each institution going forward should commission it. And say this is an exciting new approach to radiotherapy that really differs from other modalities. And that the potential of the technology will greatly increase with more specific radiotracers. So FDG is a nice starting point. It's the one that's the most ubiquitous diagnostic radiotracer, but it really is limited by all the other organs in the body that take up sugar. So things like PSMA or dotatate, I think will be great moving forward to get even more dose to the tumor. And that we're ongoing investigations for how to improve patient outcomes, whether that be to improve the therapeutic ratio of existing treatments or look at new ways to deliver multi-med therapy. And I'll hand things over to Dan Sam.
Thank you, Lucas. Excellent lecture.